We are looking at ICD-10s. We're also looking at things in the accountable care and also from the meaningful use standpoint and the things that we have to put in place in order to meet those quality measures and then be able to get paid. So we're relying significantly on our software vendors to be able to put the components into our systems. And then we're having to change our processes and procedures to meet what's being put into those systems. So that means teaching doctors, nurses, and anyone else that has to gather data on how to do that the way the system needs to collect it. And one of the things that we complain about, and I say we as general from a CIO standpoint, is there's so many different quality measures that have to be collected, and different organizations or different agencies want those in different ways, in different formats. And we may be collecting essentially the same thing, but presenting it in 10 different ways because they want it. 10 different agencies, they want it 10 different ways. So some commonality would be much appreciated. They're trying to satisfy so many different masters, so to speak, in that they need to provide that data in so many different formats that they would like to see it, one common data set, so to speak, that can go out to multiple different agencies and let those agencies glean from that what they need. That's an issue for them, and I understand because it takes programming time, and it takes a lot of time for the vendors to get the systems together to meet the needs of the regulations. And in some cases, they're not being able to do it and get it tested and get it to us in the time frame that we have to have it to meet our requirements. It's added work for us. I mean, it may be a resource that we already have, and I'm going to talk specifically about from a state standpoint. There's been some changes in the state requirements that we've had over the past couple of years, and we've had to pull the data and then do some massaging of the format of that data in order to submit it in the format that the state requires it, which takes extra time. And right now, I mean, we're looking at, how can we cut cost? And this is just an added cost for us, which one of my big complaints is that takes away time that we could really put toward patient care. We've gone to voice recognition system, and being able to put in discrete data elements via a voice recognition system is a great idea to me. But that changes that physician from being able to just sit there and dictate as if they're talking into a phone to go into each of those specific fields in the system and saying a specific word so that it gets in the discrete data element field. And it's a significant workflow change. And it's a significant change in the way they've done business for 30, 40 years. It takes time for them to learn. It gets us to the point that we can get a lot better at our quality measures themselves, which in the long run gets us to the point that we can do a better job of taking care of the patient. We can also see those, for the lack of a better way to describe it, those idiosyncrasies when we see those very strange anomalies when it comes to patient care, and a patient has something specific and you start trying to compare that. And I've heard examples over the last couple of weeks of doing national searches on things that are very rare. But you won't find those unless you get down to the point that you're getting those e-measures so that those kinds of things can be distinguishable. And we essentially cannot do that with paper because that's trying to find a needle in a haystack. And you've got to have that electronic in order to find that needle in the haystack.